Hi everybody, my beloveds. Today's topic is about gestational diabetes mellitus. Let's clarify some points, so questions that misunderstood by you on these previous several years board exams. Okay, so gestational diabetes mellitus is defined as glucose intolerance with onset or actually first recognition during pregnancy, like this. First recognition during pregnancy. Then, pregnancy itself, it's inherently diabetogenic due to placental hormones. My beloveds, so during the second and third trimester, the placenta produces increasing amounts of hormones like human placental lactogen, HPL, progesterone, cortisol, and prolactin. These are vital for fetal growth, but concurrently induce peripheral insulin resistance in the mother. This mechanism prioritizes glucose delivery to the fetus, but necessitates a compensatory increase 2-3-fold in maternal insulin secretion. Gestational diabetes arises when the maternal pancreatic beta cells cannot adequately meet this increased demand. So this it's if you want, it's a physiological stress test. So that is why this clinical importance that this physiological stress test explains why gestational diabetes mellitus can develop even in women without prior serious glucose issues. It highlights that the pancreas reserve capacity and underscore the rationale for universal or risk-based screening between 24 and 48 weeks, when placental hormone levels and insulin resistance peak. Then, gestational diabetes is a potential predictor of future type 2 diabetes mellitus for the mother. And remember that. So diagnosis of gestational diabetes unmasks an underlying susceptibility to glucose dysregulation. While blood glucose levels typically normalize after delivery, these women face a significantly elevated risk, often cited as approximately 7, 8, and 10 higher, of developing type 2 diabetes mellitus later in life compared to women with normal glycemic pregnancies. This risk is most pronounced in the first 5-10 years postpartum, but persists lifelong, especially in menopause and around menopause. So this necessitates, what is clinical issue? This necessitates robust postpartum screening and long-term follow-up. A 75-gram oral glucose tolerance test, OGTT, OGTT is a oral glucose tolerance test. No, normally it's a 75 gram is recommended for 12 weeks postpartum. Subsequently, lifelong screening for type 2 diabetes mellitus every 1-3 year via fasting glucose. Actually, for me, it's a glycolized hemoglobin. Or oral glucose tolerance test, OGTT, is crucial for early detection and intervention. Patient counseling on lifestyle modification is paramount. That is, diet, exercise, weight management is of paramount importance. About macrosomia, my beloveds, fetal macrosomia, that is fetal excessive birth weight, is primarily driven by fetal hyperinsulinism. So elevated maternal blood glucose readily cross the placenta. The fetus responds to this glucose load by increasing its own insulin production, fetal hyperinsulinism. Insulin acts as a major growth factor in the fetus, promoting glucose uptake and storage, particularly as fat, so-called adiposity, often defined as birth weight 4,000 plus. It can also contribute to disproportionate growth, for example, larger trunk and shoulders relative to the head. Clinical importance of that. So macrosomia significantly increases risk during delivery, including shoulder dystocia, It's an obstetric emergency. Birth trauma, brachial plexus or brachial plexus injury, clavicular features, operative delivery, cesarean section, and neonatal intensive care unit admission. Strict maternal glucose control is a key to minimize the risks. Okay, so strict maternal glycemic control is a key to minimizing this risk. Then, neonatal hypoglycemia is a critical and common acute complication. So, what does it mean? So, the fetus develops hyperinsulinism in response to the high maternal glucose environment. After birth, the continuous supply of glucose from the mother via the placenta ceases abruptly when the umbilical cord is clamped. However, the newborn's pancreas continues to hypersecrete insulin for some time. So this persistent hyperinsulinism in the face of reduced glucose supply leads to rapid glucose uptake by the infant's tissues, causing neonatal hypoglycemia, low blood sugar. What is clinical importance of that, my beloveds? Neonatal hypoglycemia can manifest as jitteriness, lethargy, poor feeding, apnea, seizures, and, if severe or prolonged, can lead to neurological injury. Anticipation, early feeding, Bristol formula, and routine blood glucose monitoring. Of course, breed is okay, better. And routine blood glucose monitoring, heel stick tests are essential for infants born to mothers with gestational diabetes mellitus. Intravenous glucose administration may be required. So significantly, yes, about toxications. Intoxication is gestosis, pregnancy toxicosis. That is eclampsia, preeclampsia. Of course, gestational diabetes mellitus increases the risk of preeclampsia and all spectrum of metabolic spectrum. So women with gestational diabetes mellitus have a substantial higher likelihood, often estimated as roughly doubled risk of developing preeclampsia compared to their normal glycemic counterparts. The underlying mechanisms are likely multifactorial and interconnected, involving shared risk factors like obesity, older maternal age, insulin resistance itself contributing to endothelial dysfunction, systemic inflammation, oxidative stress, so all pathways implicated in the pathogenesis of preeclampsia. What is clinical importance of that, my beloveds? This necessitates heightened surveillance for signs and symptoms of preeclampsia, so new onset hypertension, proteinuria, severe headaches, visual changes, epigastric pain throughout the latter half of pregnancy in women diagnosed with gestational diabetes mellitus. Regular blood pressure check and urine protein assessment are vital components of their antenatal care. About protocols, next point. Screening protocols, my beloveds, screening protocols aim to detect gestational diabetes during the peak physiological insulin resistance. So universal or risk-stratified screening is typically recommended between 24-28 weeks of gestation. The window corresponds to the period when placental production of diabetogenic hormones like HPL, human placental lactogen, is maximal, leading to the highest degree of physiological insulin resistance during pregnancy. Common screening methods include a two-step approach or a one-step, 2-hour or no OGTT, oral glucose tolerance test. Clinical importance of that, so understanding the timing rationale reinforces the importance of performing screening within the windows for optimal detection rates, adherence to standardized diagnostic criteria. I can mention that it's not obligatory to remember all this for your big board exams. For example, Carpenter-Constant diagnostic criteria, National Diabetes Data Group, or International Associated of Diabetes and Pregnancy Study Groups, IADPSG. This is International Association of Diabetes and Pregnancy Study Groups. So it doesn't matter. So adherence to the standardized diagnosing criteria is crucial for accurate diagnosis and subsequent management initiation. So early screening may be warranted, why not, in high-risk individuals, family history, etc., and so on, obese persons, ladies. Then, management centers on achieving euglycemia similar to non-diabetic pregnancies. Actually, euglycemia means normal glycemia. So the primary goal of gestational diabetes mellitus management is to maintain maternal blood glucose levels with tight ranges, closely mimicking those of healthy pregnancies, thereby minimizing fetal exposure to hyperglycemia and reducing associated risk. Commonly accepted targets, though minor variations exist between guidelines, are often, but fasting glucose less than 95 milligram deciliter, equivalence 5.3. Actually, I don't know, you will be asked about that or not, but just remember, 5.3 millimoles on liter, it's a upper limit. Then 1 hour postprandial, 1 hour. Postprandial means after eating. So 140 milligram deciliter, that is 7.8 millimole liter, or 2 hour postprandial, less than 120 milligram deciliter, that is 6.7. No, you have to remember the numbers. So the clinical importance of that. So achieving, my beloveds, these targets typically involves in a prolonged approach, starting with medical nutrition therapy, often guided by a registered dietitian, and appropriate physical activity. Regular self-monitoring of blood glucose is essential. Know that, no question, no doubt about that. If lifestyle modifications are insufficient, rarely, to meet targets, pharmacotherapy is initiated and titrated as needed. So what about pharmacotherapy? Insulin remains the gold standard. Metformin and glyburide, actually I don't know how to pronounce glyburide, it might be glyburide, might be glyburide, no idea. Glyburide, you understand. And oral options, so metformin and glyburide, oral options with ongoing discussion about placental transfer and long-term data. And actually about metformin, I've got some controversial. And anyway, but crucial is lifestyle modifications. Then, about babies, offspring, intrauterine exposure to gestational diabetes mellitus. Be careful, pediatricians. Confers long-term metabolic risks to the offspring. The concept of fetal programming, often linked to the development origins of health and disease, hypothesis, suggests that the in utero environmental can influence long-term health care trajectories. Okay, you understand that hypothesis. The concept of fetal programming, often linked to the development origins of health and disease, this hypothesis suggests that the in utero environment can influence long-term health trajectories, and highly likely that exposure to maternal hyperglycemia and fetal hyperinsulinism can lead to epigenetic modifications and altered metabolic pathways in the offspring. These increase their lifetime risks of developing all spectrum of metabolic syndrome: obesity, impaired glucose tolerance, arterial hypertension, gout, type 2 diabetes mellitus, compared to offspring from non-normal glycemic pregnancies. So what is clinical issue of that, my beloveds? This highlights the intergeneration impact of gestational diabetes mellitus. Counseling mothers about these potential long-term risks for their children is crucial. Promoting breastfeeding is the best, which may offer some and very good protective metabolic benefits, remember that. Encouraging healthy dietary patterns, physical activity, and weight management for the child throughout life are important preventive strategies. Of course, if the lady is with preeclampsia or eclampsia, her breastfeeding, her breast milk is not of good quality. But anyway, first should be not a glucose, but mommy's milk, breastfeeding. Then risk factor extend beyond obesity. with ethnicity playing a key independent role. Actually, no idea why. It's a lot of speculation about that. While traditional risk factors like obesity, what is obesity? Like body mass index, BMI, advanced maternal age, 30 plus, family history of diabetes, and the personal history of gestational diabetes are well established. Ethnicity is a significant independent predictor. Individuals of South Asian, East Asian, Hispanic, Native American, and Pacific Islander descent exhibit a higher prevalence of gestational diabetes mellitus, often developing it at the lower BMIs compared to non-Hispanic white populations. So, clinical importance of this necessitates awareness and potentially adjusted screening strategies based on ethnicity, independent of other risk factors. Clinicians should maintain a high index of suspicion in these populations and understand that the gestational diabetes mellitus is not exclusively linked to being overweight or obese, or after pregnancy everything is finished. No, unfortunately no. Then, my beloveds, gestational diabetes mellitus represents a spectrum of severity with varying clinical implications. So, gestational diabetes mellitus is not a monolithic condition. The degree of glucose intolerance can range from mild, for example, requiring only dietary modifications, perhaps 1 maxi 2 abnormal value on OGTT, to severe, high fasting glucose levels early in pregnancy, require significant insulin dose, etc. So the severity often correlates with the risk magnitude for both maternal and fetal complications. Clinical importance of that. So recognizing the spectrum influence management intensity and fetal surveillance, more severe gestational diabetes mellitus may necessitate early initiation of medication, unfortunately, more frequent self-monitoring of blood glucose level, and closer fetal monitoring. For example, non-stress tests, biophysical profiles in the third trimester, and may impact decisions regarding timing and mode of delivery. It reinforces that individualized care based on glycemic control and associated risk is essential. So thank you very much for your attention, my beloveds. God bless you. Don't forget to follow and subscribe my YouTube channel as well as my Telegram, Dr. Y channel. It's a private. On Telegram, it's a private. Don't go there. So you type in searching mode in Telegram, Dr. Y, W-H-Y. Dr. Y, it's me. Without question mark, without. Just Dr. W-H-Y. You find this, you click start, and you choose your plan. Stay blessed. Hallelujah.